afternoon, everybody. Before I start, I bow to the divinity in all of you. So the topic is basically about prosthetics and orthotics. So this topic is basically, as the topic suggests, like at this particular point of time, at 21st century, when we find out somebody, because of some or other reason, they are losing the hands or legs or any extremities and all, or they have certain deformities or some specific deformities related to congenital conditions and all. So how we treat and what advanced mechanism that we deal with. So before going to the topic, so this is what we are going to talk on. So the objective is basically, here we have a patient here who is using a above knee prosthesis. So it's like important possible to enhance mobility and independence for amputees as a result of various medical conditions or road traffic accidents. So the basic big picture, what we see at this point of time when we see a case of such kind, protect the sound side, that's very important. Mobility will improve, general health, because once they start walking with a prosthesis and all, definitely their health, the social inclusion will be there. Productive lifestyle, they can go back to their own work, job, whatever they are doing. And positive psychological impact, that's very important, because if they will be not walking properly, the mobility will be stuck, so they will be having psychological issues and they may think things in a different way. So we not only a prosthesis just to we give them a prosthesis not just to make them walk, rather all these factors also we consider. So the topics that basically we are going to see is amputation, ideal stump, post-operative care related to prosthesis, lower limb prosthetics, upper limb prosthetics, orthotic management on diabetic foot, brief about customized and whatever the ready-made orthosis available over here. So amputation is a brutal and destructive surgical removal part of a limb at a level determined by the tissue viability and healing potential of the created stump and biomechanical function of the post-amputation prosthesis. So what is the ratio basically when we see men is to women, trauma 9:2, men is to women, disease 2:6. So this is just a coincidence, this is the incidence that we have got related to amputation. Level of amputation, so different level of amputation on lower extremity or upper extremity starts with from a finger to shoulder or from a toe to hip. This is even now, I mean, there are conditions that we have seen translumbar amputation, which is very rare, like in worldwide 2 or 3 cases been done. So this is what gives hindquarter hip disarticulation transfemoral. Then again transfemoral is further divided into depending on the percentage of the length of the stump. So that will be like short, medium or long. Then we'll be coming to knee disarticulation. Then again transtibial. So transtibial also the same, like short, medium, long, depending on the percentage of the length that we keep as a for the prosthetic fitment. Then ankle disarticulation, partial foot amputation, so transtarsal, which we can say is chopper. Then tarsometatarsal, that is Lisfrank's, and hallucis or digit or ray amputation. Symes also will be there through the ankle also some movement because of some conditions that we do. Then upper limb again the same, forequarter, shoulder disarticulation, transhumeral. So again when we coming to the main bone, so this different length will be there. So in those length we say is a short or long or very short. Then elbow disarticulation, then transradial. So transradial also will be the same way, short or long or very short. Then wrist disarticulation, partial hand amputation, transcarpal, transmetacarpal, transphalangeal. So these are like depending on the conditions. So nowadays we see many cases with finger amputation and all. So those like for any specific finger amputation, we don't be able to give some kind of movement on those conditions because we don't have a leverage. So we give cosmetic restoration and all that some point we do. Then if we think about ideal stump, normally any level of amputation, whether it's ideal or non-ideal, we have a prosthesis. But suppose when there is a case where we planning for a plant surgery. So plant surgery, if we consider these particular points, so we will be having a good stump. So for that the prosthesis fitment will be better, the outcome will be better. So in these conditions, so healing of the stump should be properly healed, skin and scar, soft and healthy pliable skin without any scar mark. Enough gliding movement must be present between. skin and soft tissue. Then limb length, so if we see is transtibial, normally we say is the structural length, the bone length, 2/3 if we can preserve, that's a really good stump. But if specifically we see is 13 to 15 centimeter in a below knee amputation. TF, that is transfemoral, 17 to 25. Then transhumeral, gap of 10 centimeter above the elbow axis. Then below elbow, that is transradial, 13 to 15 centimeter from elbow axis to the stump end. Then limb volume. So transtibial, it's tapered or cylindrical shape. So it gives good control. We can control the muscle movement and we can use the patellar tendon. So that can be the weight bearing area where we can give the weight of the prosthesis and the patient can walk on. Or beyond, if we see that patellar tendon system is not suitable for those kind of patients with vascular conditions or diabetic and all, then we go with a total contact surface bearing socket design. Then transfemoral, which is preferably a conical shape, which we like because of the toning and doffing will be easy in those conditions. So a smaller distal circumference is always desirable because the muscular lock, some moment if there will be an end which is bit more and off it is less, so opening and closing of the prosthesis will be slightly difficult. So normally a smaller distal circumference is desirable. Range of motion, the stump should have good range of motion, free from neuroma, good muscle strength, no sign of edema or the other deformities, pain, tenderness, etc. So that particularly as doctors or surgeons that we need to take a call which is the right time for a prosthetic fitment. Normally we say is below knee prosthesis or some kind of a partial foot or above knee amputations. Normally 6 to 8 weeks after the stitch removal, then we can go for a good prosthetic fitment. But we have to see the management, like how compression and all, swelling. If at all any specific wound is there which is open, so we should not start the prosthetic treatment. We should wait till the wound heals properly. So suture lines and muscle padding, normally these are recommended for prosthetic designs. Because when we think about a myoelectric or a bionic hand and all, so we specifically need some muscle co-contraction. So muscle co-contraction always happens good in myodesis. So normally we suggest for upper extremity myodesis, or lower extremity myodesis or myoplasty will be fine, but myoplasty is the best for lower extremity. Then this applied part that you have a better idea on, but incision location for far longer than the actual bony length, durable and healthy tissue, and well vascularized. So that is what we have to see for the length selection. Then effective length, derived length influenced by the flap, not too long, not too short. Clearance to fit the prosthesis. Normally if we don't have proper length, then we may not be able to have a suspension structure for the prosthetic limb. So normally ideal length, or as we mentioned, like if at all we go somewhere in between this level, so in between the red lines, so that is a good length that we can put a prosthesis properly. I'm talking about above knee amputation. So muscle clasps, fist-bound incision, posterior distal coverage, horizontal suture line. In myodesis, abductor and hamstring balance of the hip function, appropriate tension. So normally proximal joint contracture is a very common problem that we see with amputation. When we are ready for the prosthesis, we find out knee or hip contracture. So if we have some point from this muscle tension, so that also can be controlled in a better way. Then post-operative care, when we talk about post-operative care, that comes full range of, this is before the fitment of the prosthesis, after the surgery. So full range of motion and muscular strength that we normally physio, that all things that we need to start on. Reducing phantom pain, if patients they complain of phantom pain and all, then we have a specific treatment protocol for the phantom sensation. Either we can go for mirror therapy or tapping exercises, then fine touch, screw touch. There are a couple of specific exercises as a particular patient complains of very bad phantom sensation. Then there are certain things like when we see that patients are, they go home or before the fitment of the prosthesis, or they are during the surgery, they are in the hospital, there are very bad postures they follow. The posture, some moment they use which is very comfortable for them, but probably that is not comfortable to put a prosthesis. So if you see, avoid contracture during hospitalization and wheelchair use. So if we see this wheelchair particularly, there will be having a specific strength. Let's suppose it's a below knee amputation. So they always try to bend the knee. So what we can do, if we don't have availability of this kind of stand here, we can put a pillow which will be slightly hard, so that they can put the whole leg in knee in extension, so that the contracture can be avoided. Then prone lying for 30 minutes per day, head away from the amputated side. This we are talking about above knee amputation, so that the contracture will not be there. Then stump exercises, muscle strengthening of sound side and residual side, torso strengthening exercises, because this is very important to balance the equilibrium between the both the lower extremities and the upper trunk. Sitting on a chair without backrest, because that will activate the paraspinal muscles, so that when they start walking with the early rehabilitation phase with the prosthesis, there will not be much back pain kind of thing, or they will not be having a deviated pattern of gait. Then stump bandaging. Stump bandaging is again very important when we are making a patient ready for prosthesis, so that the volume fluctuation, if once we start putting a prosthesis, if there will be further volume fluctuation, the prosthesis may get loose and all. So in those conditions, we have to make sure that post suture removal, we have a proper crepe bandaging or a stump socks that we provide to patients, in, if at all there is no existing open wounds. So this is what normally we do. Then in upper extremity also the same case, that we put the stump bandaging and all. So these are some of the things that normally we see in a hospital, what the patient they used to do, which they should not do. This will develop contracture to the proximal joint of site of amputation. Now coming to the lower limb prosthetics. So prosthesis is basically an external device that substitutes for a missing part of the limb, either in cosmesis or function or both. So part of a prosthesis, as we see over here, foot, joint, stand, socket. So the lower limb prosthesis can be classified broadly into below knee prosthesis, above knee prosthesis, hip disarticulation prosthesis. So in between also we have different level of amputation, that if at all we have a case and we don't have any other option to do, we come through a sign, suppose, or a partial foot or chopart amputation. So all this kind of amputation, we have specific prosthesis that we can fit, but broadly when we classify this way. Then if we are coming into each part, so foot, if we see, as if we remember the first topic, in 21st century, what is exactly that the advancement that we have, that if we see in the foot, the first foot suggests here is a Jaipur foot. So now we have foots that are controlled by a microprocessor unit, that there is pattern control AI based, so we can give a software to the mobile of the patient and they can control the ankle movement, whatever desired movement they want. Suppose they want to run, they want to jog, they want to do some sports activities. So all these options we can, this is purely for a sports activity, this is particularly for day-to-day life, but we'll be having a which we can control dorsiflexion and plantarflexion up to 15 degree. So normally, if somebody is very fine dancer or something, that they need that much of flexion, dorsiflexion or plantarflexion. But for normal walking pattern, we don't need this much of. So with normal any specific foot that we get, we can have a proper pattern of gait. Now coming to the joint, when I say joint is a knee joint, so it's the link between two segments of the skeletal framework that allows various degree of freedom in different imaginary planes. So if we see the same way, this is a Jaipur foot that we are, since long we know. Now coming to this is one of the advanced knee joint that is available in the world right now. We have a waterproof option of that, and this will be allowing us front walking, back walking, all desired speed, cadence, variable cadence also we can do that. We have all specific data. We will analyze the patient's gait pattern. As per the pattern, we will inbuilt in the mobile. So, or we will give them a remote control. So from that, whatever functions they want, we will they can just switch it off, change the modes, and walk on. Now the socket, this is very important part for a prosthesis, because whatever technology that you use for the joint or foot, that is not the part that is touching to your body. So what is touching to the body is the socket, because that is what is, if that is not comfortable, you put anything at the distal parameters, it will not be helpful. So socket, definitely if we see, this is a patellar tendon weight bearing socket. This is a lock liner. This is a silicone liner, basically what we suggest. So silicone liner is normally for diabetic patients where we can give a proper weight bearing. It should be total contact socket. It should not be specific weight bearing socket, because if there will be specific weight bearing socket, there will be friction. So the friction creates some kind of blister and all. Again, it will be difficult for them to walk on. So then this is a vacuum socket. So this is, here we can control the vacuum as per the need. So this particular design we say as limb logic. So in that, what happens, how much vacuum we can create, with that will show us in our screen, and that can be fitted. Suppose some moment of like even we have with this the proper sensory feedback. The venous drainage, it will be good for diabetic patients or patients with kidney disease. They will be having volume fluctuation throughout the body and all. So if this kind of socket system we are using, that automatically controls the stump, and suppose some moment it is higher, so vacuum will be less. If it is getting lesser, the vacuum will be higher. So that can control in that way. So here also the same. These are all above knee. These are all below knee sockets. This is now coming to the alignment structure. Alignment is like the geometric relationship between the socket, shank and joint. It's basically nothing that when we stand, how our CG is traveling, how the ground reaction force is working. So these all things, that for this all we have all these devices, so that we can understand whether the patient is having a deviated gait pattern. So to understand the deviated gait pattern, we should understand the normal human locomotion. How, at which page, how much angle of knee, ankle and hip. So as per that, what is the deviation and what that deviation is causing. Is it a cause from the socket, is it a cause from the joint, or is it a cause from the foot? So in alignment, again we do two kinds, in static and in walking. So when we do static alignment, maybe the patient might be looking better, but the moment they start walking, then there will be some kind of deviated force acting on the socket, or they will be having back pain. They may complain of many specific things. Now being surgeons, you must be coming across patients using prosthesis since long and complaining of back pain, or there is a trunk bending, all these things. So in those conditions, first thing probably I will say that we should see into the prosthetic point, whether there is a short length or some kind of pressure the patient is getting. Because of that, he is trying to relieving the pressure from that. So all these things is very important. Once we see that, if we don't consider that point, normally now there is studies that we see prosthetic users, they easily get early OA. So because of bad pattern of walking, high energy expenditure, there will be sliding and gliding movement will be very high. So they below knee prosthesis or above knee prosthesis they use, they will be having normal side knee pain. So these also prosthesis also has a great impact on those conditions. So a good prosthetic line properly aligned is very important. Now coming to the upper limb prosthetics. Upper limb prosthetics can be classified further the same way: below elbow prosthesis, above elbow prosthesis, shoulder disarticulation. So apart from this, we have individual finger amputation or some way. So those, but broadly we classify into this: elbow disarticulation some moment, wrist disarticulation some moment. So these all will be coming, but broadly we classify like this. So with technology touch, this can be further classified into each type as follows: as cosmetic, mechanical and myoelectric. So myoelectric is nothing but the bionic hand that we are going to talk in subsequent slides. Cosmetic is nothing, as the name suggested, it's just a cosmetic hand. There will be no movement, just we provide it just for the replacement of the part to be missed. There will be no functionality in that. Now coming to mechanical. Mechanical will be like we use some kind of specific harness system. We add some spring and also whenever we use, suppose it's a below elbow amputation. So what we do, we take the elbow function, elbow flexion and extension, so that the hand will move, the terminal device will move. In prosthetics, upper extremity, normally we focus more on three-jaw chuck prehension. Basically that is what is very important, the thumb, the index and the middle finger that normally we use for maximum per activities. So we also some moment classify that into that category. Then if we go into the parts: harness with control cable, socket system, arm segment, elbow unit, forearm segment, wrist unit and terminal device. So this, if we see, this is a cosmetic option. This is a cosmetic hand, this is a mechanical hand, this is an electronic hand. So Further, how a bionic arm or a electronic hand or a myoelectric hand that works. So myoelectric prosthesis function is like basically wrist rotation, flexion and extension of the wrist, digit movement. So when we talk about digit movement, either it will be a three-gesture prehension or five-finger movement also. So basically how this functionality works, so we have a myotesting. What exactly is myotesting? Is normally very simple language, we take the action potential available on the muscle and we have surface electrodes. We have different kind of electrodes like needle electrodes or surface electrodes, but we don't go beneath the skin. Over the skin itself we take with the surface electrodes. What is the action potential available? Normally, once we receive the action potential, then we consider whether that much of action potential is sufficient to move the hand. Then we'll be having amplifiers which will amplify it further. So myotest, if we say, it's a tool to search the best possible positions for the electrodes. Require two different signals for opening and closing the terminal device. Suppose some moment we have a case with a very bad burn case. So we may not have a muscle which is flexor or extensor we can distinguish in those conditions. If we have only one compartment also, in those conditions we can put a prosthesis. So in those conditions, what we are going to do, we will be giving a higher signal which will be for closing and lesser signal will be for opening. So this is a safety mechanism, because some moments a patient is holding something, they may not be able to give a higher signal immediately, but lesser signal they can give immediately. So when these conditions where we don't have a distinguished signal on both sides, both the compartments, both flexor and extensor compartments are not working. Now how it works with the brain. Electricity from the skeletal muscles appears with a voluntary muscle contraction. The voluntary control is one of the excellent attribution of myoelectric control. A myoelectric system will work only when the person with the amputation generates voluntary muscle action. So everybody, we can't put a myoelectric prosthesis unless and until they have a good control, good action potential is available. Any kind of muscle contraction is not available, then it's very difficult to put a myoelectric prosthesis. So some moment if we find such cases, so the most important thing that we look into is, we suggest into is a physiotherapy that they have to do. Then we can find out some kind of, we do a electrode test. So in that test we understand where exactly how much action potential is available. Then we take that area as a electrode placement. So this is how it works. Normally the action potential is very high at the muscle belly. So normally we suggest as the belly area to for the control mechanism. Then coming into the training with prosthesis, because this is very important. Once we put a prosthesis, they should also know how to control the prosthesis. When talking about upper extremities. So these are some of the ideal activities or ideal devices. Some moment they may not be able to hold properly a spoon, and also we have to modify slightly, or they may not be able to comb the hairs with some stand, with some bigger stand we have to plan. So these are some of the things as per the patient's need that we can plan. And also we have options, software based options, that can be a mobile app. In that we can add on whatever their activities, and whenever they want those activities, it will be working on that. So these are some of the functional specific designs that we normally do when they can do some fine motor activities. Now coming to foot orthotic management, in particularly diabetic foot, it's a very vast topic, so it can be a topic itself. We have specialized baropedogram studies that we take. We do posture analysis, we do their specific temperature analysis. Then we see whichever conditions they have a specific area which the pressure is coming in a very high way, so that will show us in percentage manner. Then as per that we take a call which area to be reduced, offloaded, which area we can give some pressure, and if at all how it is helping. Again with the same device, with the gait analyzer, we can make them stand, and we can show that the particular pressure that before how much it was coming, and now after using some kind of orthotic intervention how it is working on. So this is particularly some in diabetic conditions where there is a diabetic neuropathy, there is the foot and ankle structure is totally having very less stability and all, and sensation is impaired. We can give some pneumatic compression boot that normally holds the alignment and allows the patient to walk we'll be giving a roller surface, that is a rocker surface on the down, so that the stress to the ankle joint will be less. Then coming to customized orthotics. So orthosis, when we say, is prosthesis, when we say, is the part is not available and we put a artificial part, but orthosis, when we say, is the person's body part is available, there is because of some disease or some conditions it is weak, or if they are not able to move it, or the function what is meant to be done is not, we are not able to do that over there. So then we can give some customized devices. So if we see here, there will be why we provide a orthosis, like we provide orthosis to control, support, immobilize, correct, prevent or assist. So it will be an external device which will be applied to attend to improve functionality of a segment, control movement of better stability, support a affected segment, reduce pain by directing load to another area, correct flexible deformities, prevent progression of deformities, assist movement. So these all things that once we understand the deformity, we analyze the force lines. So how it is, if it is a small kid, in those conditions we may correct the deformity. If it is a matured deformity fixed, we can't do much. So what we can do is we can support so that further deformity will not happen. So this way we see into supportive devices. So we have a portfolio that basically, if we talk more about it, this is grossly divided into determine the cell design and deformity analysis. So deformity analysis, like we have to see whether it is in foot or ankle structure or at the knee, or the deformity is still the hip. After we understand that, then we understand whether we are going to give a ankle foot orthosis or a knee ankle foot orthosis, or we have to control the hip also. Some moment if it is a spinal condition where there will be traumatic conditions and there is compression or complete there is knobs and all, so there will be having paralysis, or in those conditions, once we understand the deformity, then we will be suggesting which option will be suitable. Now cell design is basically when we understand the load line analysis, then we decide a cell design. So each here, if we see, these are all 3-point pressure system, how we are controlling here the condition where knee valgus with flexion deformity. So this is a flexion deformity. If we see this in this plane, this is the corrective force, these two are the force that is counterparting. So the same way when will be valgus condition, so the lateral 2 forces and medial 1 force which will be correcting. So for each deformity, how to design, normally when we say in a conventional mechanism, in a conventional orthosis, we only think about a posterior cell. But here always it's good that first we analyze the deformity, then the load line, then we take a call what kind of design or what kind of brace that we should provide. Now this is what is the normal, the ground reaction force and the wet line, how it passes on frontal and sagittal plane. When we see this condition, so here our normal line and the body, the patient's body is somewhere here. So here we have to correct this. But in these conditions, correction, how much correction is possible, that is also very important. Because at this age, at this point of time, probably if we say that with the orthosis we can correct to the whole, it's very difficult. So we have to understand how much force which is applicable and that is viable to the patient's body. The same way it is about the individual designs of the braces, that what we have talked before. So then the most important point comes over here is the muzzle test results. So grossly, if we see any kind of AF or KFO we provide, whether to give movement or whether not to give movement, the most important factor that we should understand is if 2 extensor loops are more than 2 plus or 3 the muscle power, then we can give mobility. If we see the patient's condition is like less than 2 or 2 plus 2 extensor loop consecutively, then we have to go with safe mobility. So in that way we have categorized, this is an international classification, we understand in that way whether to give a safe mobility, whether to give a enhanced mobility. Enhanced mobility in the sense, if we are providing a caliper kind of thing till hip or till knee level, where whether to provide the knee movement or not. So that we consider as per the muscle test report. So this is also the same, exactly more elaboration about the deformity. Now coming to the AFO, the same way as we have discussed, this particular design, when the deformity is within around the ankle and foot, the deformity is not to the knee or higher levels, and we can only cover below the knee area, and we can give the support system. And the same way how we analyzed in the above knee conditions like caliper, we have a KF4 design or HK4 design. The same way for the AF4 design also we do. So this is what deformity, how it happens, and what is a muscle power, and what should be the correction force, and what kind of implant that we use, how it controls. Now coming some readily available bracings that we normally day-to-day life we put on for fracture cases or post-surgical condition or a foot drop or knee pain or ligament reconstruction. So many conditions are with spinal conditions where there will be compression of the disc like lumbar area, or there is a fracture at the thoracic area, or also we have specific designs related to the spine where we can, very cervical, very higher cervical, we can put a halo. So that can also give conservative treatment that we can keep it, and for the healing of the bone and all. Or SOMI brace, which we can come across, is like if it is lower thoracic or upper thoracic or lower cervical, in those conditions we can immobilize the spine and we can give a good support system where there is no surgical intervention is required. Where surgical intervention is required, that's your call how to go ahead. So foot and ankle, like this is a very specific ankle foot orthosis. This is a carbon fiber design that are readily available. Normally cases where we see there is no chance of recovery. There will be certain conditions where with exercise, with therapeutic management, there is a chance of recovery. So we don't suggest on those conditions carbon fiber or AFO, because that takes over the function. Where we find that there is a chance of recovery is very less, since long there is a foot drop and all. So then on those conditions, to take over the function, to give a proper good gait pattern, we suggest this kind of braces. Spine already I discussed. These are some of the specific designs available. Whether anterior support, we give some sternal support to control the hyperextension. Then beyond this, we have cases where we'll be finding scoliosis, and also in those conditions we have to go with customized braces. Basically, we have to analyze the corpse angle. Then we have to see whether it's a flexible deformity or it's a fixed deformity. Then we have to also see whether because of that deformity is there any secondary deformity to it. Then we have to plan the cell design, the force action, the same. The very basic principle of any orthotic device is a 3-point pressure system. We can divide that 3-point into 5-point or 6-point pressure system. So how it here, the normal very basic lumbosacral belt, how the function works, intra-abdominal pressure inside the lumbar spine and reduces the intra-discal pressure. So this is what the very basic understanding when we suggest a spinal brace, because that over the ASIS we give the constant support. From that the leverage works for the further force system. So knee injuries, as we have very specific knee braces available now for conditions where there is a reconstruction of ligaments or early OA, or where there is a condition of OA where surgery is not indicated. We can suggest different kind of braces depending on the condition. Now for the shoulder also, for all the part we have some or other kind of braces. So this very important braces that we normally put. This is a particularly aeroplane splint. So when we suggest cases with rotator cuff injury or some kind of immobilization required to the shoulder joint at particular angles, so for some pathologies, so we can put this kind of braces as required with concerned consultants understanding how they want, which angle they want. So we can put and do. Then the other way we can see is omonerexa. That's a supporting brace. Normally stroke cases will be finding shoulder hand syndrome. In those conditions, because of the gravity, the shoulder drops down, and that affects the gait pattern a lot. So we have also done a study on this particular brace. Because of the shoulder drop, there will be a condensation to the lungs also in the long run. So when we properly correct the shoulder in proper position, that again there is a study that the condensation reduces. So these are very important bracing. Some moment when we find cases of very long standing stroke and this problem is there, so we can suggest some kind of customization of this type of braces. wrist and hand is common injuries of the wrist and hand that we day-to-day life we face. So these all braces, they either give some functionality in a particular position or rest. So this is what basically we look into. Dynamic bracing and all is like, suppose there is a relearning process after tendon transfer and all. So those all we do customization. So now if we think about the first slide that we had talked about, the gentleman, he is a above knee prosthetic user. Now we have, in these conditions, we have a liner, we have a suspension system, we have a prosthetic knee joint, and we have a foot which requires what kind of movement that we want. And the person really can focus on his day-to-day activities rather concerning on a prosthetic, what is happening in my artificial limb and all those. That is what is our main concern at here at this point of time, that if somebody is using a prosthesis and all, how much time in a day they think about the prosthesis. So if they are thinking a lot about the prosthesis, then definitely must be some kind of or other reason that we have to look into. So this is what all the solutions that we look into, and then we plan for the further management. So that's all from my side. Thanks for a nice hearing.